Hello, everybody. Welcome to another edition of Intellectual Calisthenics. I started this YouTube channel to basically pique my intellectual curiosity and have interesting conversations with experts in different fields. Today, I am honored and privileged to have my friend, my partner in crime, my associate, Dr. Natasha Iyer, and both of us are in Alberta in Canada. And I will let Natasha introduce herself. So Natasha, over to you.
Thanks, Shabnam. Well, of course, that was a lovely introduction. Thank you. I call you my brainiac super brain friend and colleague. So thanks for that. I practice functional medicine in Calgary, Alberta, and we look at helping people live younger, longer. In essence, in a world where everybody talks about lifespan, what does that mean when more people than ever have a terrible quality of life at the end of their lifespan, in long-term care with chronic disability and disease, and there's no actual enjoyment of life, as opposed to health span, which is how long are you healthy for, so that you can do whatever you want, whenever you want. And so that's the field I've dedicated my career to, and so have you. So that's what we do here.
Thank you, Natasha. So both of us are fellowship trained from the American Academy of Anti-Aging Medicine. And our perspective is from the view of therapeutic lifestyle change. So I just wanted to make sure that people understood what our biases are, if you will, because I'm going to start off with a very interesting question. So the topic we're going to talk about today is fatty liver. And I will share a few slides. That's just to make sure both of us stay on track, because we can just, meander all over. So fatty liver.
While you're doing that, let me just add that, when you say therapeutic lifestyle change, our field of functional medicine, and I like to call it longevity medicine, is dedicated to using all the advances modern science has given us. There's so many new studies and papers that you look at and share with me, and information that we come across that's not considered mainstream, even though it's published data. And it's not mainstream because there's no drug or something associated with it as a magic cure. And we're looking at all of the things that rob patients of good, healthy life, and the lifestyle changes, and any other interventions we can make, including hormones, nutritional supplements, lifestyle, all of those things. So I think it's an all-encompassing field, and it gives me such great joy to watch people transform their health and their lives.
Thank you, Natasha. So, I have started recently calling fatty liver diabetes of the liver. And this came up from a conversation with a patient who said, so how traditional medicine will look at, okay, your blood glucose levels are not in the diabetes range now, and you and I are saying, no, it's already high, it's high time you started taking action. Right. So this was a person whose blood glucose was, in our opinion, already high, so it was high time he started taking action, and he had a diagnosis of fatty liver, and he's telling me, I don't have a problem of diabetes. I only have fatty liver. So now here I am trying to explain to him, fatty liver is diabetes of the liver. So Natasha, do you get accused of, bringing insulin resistance to every illness? Like I am frequently, no one tells me out up front, but they say, you talk about insulin resistance, whether it's heart disease, whether it's like brain function, whether it's fatty liver, whether it's PCOS. So do you get that, Natasha?
I don't actually, and I think it's because a lot of patients come to me for more hormonal issues or symptoms dealing with hormonal imbalance, even the stress and other things that cause health changes and decline. And so we look at things in context of each symptom that they're having. And so, when it comes to weight and heart disease and pre-diabetes, then yes, absolutely, we're talking about insulin resistance. I don't see a lot of PCOS, to be honest with you. I think your patient demographic.
Yeah.
My patients are classically in their late 40s and older for functional medicine. And so by then, many of their PCOS issues have already reared its head and they've worked with someone like you, or and you know, typically you're finding it in your young women with
Yeah.
fertility issues. So no, I'm not seeing a lot of PCS to go there.
Okay, so anyway, I'm just going to. So the question that Dr. Iyer and I would like to address today is fatty liver a druggable or a lifestyleable problem? And I'm going to, before we actually, of course, it's obvious that you and I will have a different perspective because we are more in favor of lifestyle versus a
My
drug.
first, my first question was drugs.
Sorry, prescription medications.
No, I understood that part, but I mean, you know, as is commonplace in our practice and with the patients that seek to see us, they're looking for more natural ways to enhance their health and restore their health. So I think for the most part, my clients are not looking for drugs off the bat. However, everyone struggles with lifestyle changes. And I think you and I both know this. This is why you're certified in Tiny Habits, right? And it's
Yeah.
because we just have struggles changing what we eat and how we eat and when we eat. And it's sort of the longest journey anyone can take. And I can speak from personal experience, as can you. You know, that is truly, it would be easier to take a pill.
Yeah, okay. So before we go ahead with what is fatty liver, basically, Natasha, where does the fat in the liver come from? So this is the medical definition is non-alcoholic fatty liver disease or NAFLD. This results from liver damage due to the accumulation of fat or triglycerides and inflammation within liver cells. Now, in the interest of time, I'm going to rush through a little bit so that there are some terms we need to define. One is what is NAFLD, what is NASH, what is,
Then
MAFLD.
you do that
So
because you speak with less words than I do. So you go.
thank you. So, Natasha, if you remember, sometime back we were having this conversation about, why do we need to say non-alcoholic fatty liver disease? Because you studied medicine in South Africa and I studied medicine in India. So back when I was in India, we used to call the medical college. For us, anyone who comes with any liver problem, whether it would be cirrhosis, and of course, I'm not talking about hepatitis, we would always say that people who drink excess alcohol, they usually lie, so they are actually drinking more, they're not telling us. So Natasha, you and I had this conversation about whenever anyone talks about the liver, it's always about alcohol. So obviously those people who don't drink more than they should, they are thinking, why do I have fatty liver and why, like, I don't drink alcohol. So in 2020, they decided that I think it's time to call it metabolic associated fatty liver disease so that people get that, I don't drink alcohol, so this is not really my problem kind of a thinking. Because the fact is, non-alcoholic fatty liver disease is a problem of metabolism. So Natasha, would you add a few words about, I know you would agree to moving into MAFLD instead of NAFLD, but again, most people know it as fatty liver and not as MAFLD. But I'm sure you're going to agree with the MAFLD name.
The thing is, yes, you know, when we, and I mean, like, heck, I've been graduated over 25, 26 years now, and you too. So, you know, in the old days, we used to call it, we used to always think about alcohol as the only issue, and we never recognized that it had anything to do with insulin resistance. Although 26 and 30 years ago, the diet was not as bad in the world as it is today. Our carb consumption wasn't as high, our sugar consumption wasn't as high, and I worked in a more rural community too back then. So when we saw liver disease, yes, metabolism and sugar and insulin resistance were never on our mind. In fact, just as I was graduating is when they first started talking about the metabolic syndrome, and it was called Syndrome X at the time. So dates us quite a bit in our fields, but Syndrome X, and it was just this thing that was being discovered. So we didn't have enough information then. But, you know, fast forward to today, whereas back then, most liver failure and liver transplants and death from liver disease was alcoholic related if it was cirrhosis. I mean, we're not talking hepatitis and all of those sorts of things, but the infectious things. And yet today, fatty liver or NAFLD or MAFLD, whichever you want to call it, it's more, it's the higher driving cause of liver failure today.
Yeah, you are absolutely right, Natasha. Actually, I don't remember seeing any fatty liver when I was in med school. And, that was 20, 30 years ago. Versus today, it is like an epidemic. And the scariest part is children are being diagnosed with fatty liver. In fact, I got a real shock, before the pandemic, I had gone when I was visiting India, and I'm from a small town in Eastern India. I saw a big banner for liver transplant in this little place. And I thought, oh my goodness, like, where have we reached?
Yeah.
This is like liver transplant was not something common at all, earlier. And now my, small town in Eastern India has a liver transplant center, and kids having, fatty liver. This is like, I mean, I don't know. There are so many things that we need to address. So the point is, Natasha, where does this fat in the liver come from?
So, I've had so many patients, because I see patients as a consultant, right? And I look after longevity medicine with them. And what's really interesting is they'll say, oh yeah, no, I know I'm on fat. I have a fatty liver. That's why I'm following a low fat diet. That's what my doctor said I should do. And I said to them, fat in the liver doesn't have to do with fat in your food. And I'm so glad you brought this point up, because that's what the average person would think, right? You call it fatty liver, you assume it has to do with fat. So you assume you have to eat low fat if eating has something to do with it. So you go ahead and be very succinct, because I will take a long time.
Thank you, Natasha. So the fat in the liver does not come from fat in the food. That is what Natasha has made that very clear. So where does the fat come from? Obviously, your liver has the ability to make fat from other stuff, carbohydrate being one of the big ones. So we talked about insulin resistance. So insulin resistance, in very simple terms, is a problem of your insulin carbohydrate metabolism. And how it shows up in someone depends on, again, I'll come to that later on. So putting it in very simple terms, it's a problem of you are eating more carbohydrate than your body is able to tolerate. So that, makes your insulin carbohydrate metabolism, inefficient. And that can show up as hypertension and fatty liver and, rising blood glucose levels, a lot of different things. But it's not the fat in the diet. So, yes, Natasha, go ahead.
Because I think really at this point, we need to say insulin, when you eat the carbohydrate, it's the insulin driving the fat formation from carbohydrates. And so
yes,
when you're saying insulin carbohydrate, let's just say that when you eat carbs, it stimulates insulin production, and insulin takes that carbohydrate and creates fat molecules out of it.
So basically the problem is glucose, which is in carbohydrates. Fructose is the other big one, and amino acids, which are basically the building blocks of proteins. They are not as big a source of, the fat in the liver at all, because particularly if you're eating more carbohydrates, more fructose. So here I just want to stress a little bit more on the problem of fructose, because many people don't understand why fructose is such a big problem. And before I go to fructose, I think, Natasha, I would just like to, finish up with a few terms, because sometimes some of these terms are confusing to a lot of people. So what are the different stages of liver damage? First is, of course, a healthy liver. And the liver is such an underappreciated organ, Natasha. Would you agree with that?
For the general public, yes,
Yeah.
I would say so. For our type of clientele that come to our clinic, they're very aware of the liver, because they're aware of how important detoxification and metabolism are. And because we're dealing with hormones, they all go through the liver. So we're talking about the liver from the first moment they meet me. And it's less of a mystery to my patient load.
Yeah, but I'm just talking about in general, people don't think of the liver other than in relation to alcohol or if they have hepatitis. Anyway, this is, the first one is, of course, a healthy liver, then is hepatic steatosis. So just that is basically fatty liver, steatosis meaning fat. And the next progression level is steatohepatitis. So that is when someone is, diagnosed as NASH. So NAFLD is fatty liver. NASH is when the term itis comes into anything, it means inflammation. So basically, inflammation sets in because of all these metabolic derangements. And as you can see in this diagram, up to NASH, it is still reversible. However, if it progresses further and goes into liver cirrhosis, and unfortunately, some of these patients with liver cirrhosis may even have, liver cancers. Those are not easily reversible. But in the general world, fatty liver, steatohepatitis, both are reversible. That means you don't necessarily have to sacrifice your liver for those things. Now, the next point comes, if you have been diagnosed with fatty liver, sorry, I stopped sharing the screen. Let me just go to the next slide. The interesting thing, Natasha, is most people are not dying from liver failure or cirrhosis or liver cancer. The most common cause of death in patients with NAFLD is cardiovascular disease. So disease of heart and stroke. So to you and me, this is not surprising, but would you like to add a few? Because most people think that it's liver failure, and if they are not progressing in terms of their fibrosis or anything, then they are good, but they are forgetting that they are at much higher risk for cardiovascular disease.
And thank you, because the average person doesn't even know why it's a bad thing to have fat in your liver. Mm-hmm. Now, a lot of people are aware that visceral fat is inflammatory and dangerous. I think in the last decade, there's been a lot of education about that, the abdominal fat, the fat around your heart and your pancreas and your liver. And so some people who are a little more interested in reading about health and well-being, they're aware of that concept. But when we look at fat in the liver, they still don't understand, okay, so I've got fat in my liver and it's affecting how my liver works. So now it's going to affect my hormone balance, my toxic burden, my plastics, my whatevers, but they don't connect it. So this was such an important point, that fatty liver, I would worry less about your liver because it has such enormous reserve and we can reverse it. But understand fully that insulin resistance drives all of the diseases we don't want you to get. And more people die of heart disease than of breast cancer and prostate cancer and what, like all the things that people publicize or dramatize in the, like, oh, let's do the breast cancer campaign. Yes, it's important. It is rising. I agree with you. But do you think breast cancer would be rising without insulin resistance being an epidemic? No, it wouldn't, because insulin resistance is driving the cancer. In the same way, though, insulin resistance drives cardiovascular disease and drives it hard and fast. So when you have insulin resistance, the first most important thing is then people start thinking diabetes. Well, diabetes is not just a disease of sugar control. Diabetes becomes a vascular disease, and that's how it ties in your brain, tie it into cardiovascular. So, when sugar is getting glycated, we talk about when your blood sugar goes up, that sugar molecule attaches to a protein. We call that glycation. These glycated proteins start plugging up the tiniest vessels, whether it's behind your eyes or in your brain or in your fingers and toes, the penis for erectile function. Sometimes that's what it takes to get someone's attention. But there's tiny blood vessels around your heart and in your kidneys. So in your major organs, you're getting glycation of protein, and that's how you get dementia. That's how you get the heart disease, right? We're glycating protein, and we wouldn't glycate protein if we didn't have insulin resistance and dysglycemia, which is changing of our blood sugar level outside a nice tight range that we want patients to have. So like I said, I'm very wordy, but I hope that's sort of answering the question.
Thank you, Natasha. You brought up something very interesting when you mentioned erectile dysfunction, how in our world we talk about one ED is related to the other ED. So the one ED is erectile dysfunction, which is related to endothelial dysfunction. So endothelium is the lining of cells in your blood vessels. So that endothelial layer is hugely impacted by insulin resistance. So that is the reason, some endothelial dysfunction and erectile dysfunction both have to be addressed equally. So usually, around erectile dysfunction, people have all these jokes and, blah, 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 but it is very serious.
I have an obstetrician gynecologist talking about erectile dysfunction and ED. I thought that was hilarious, Dr. Carr.
Thank you. But my point is, it is very serious, and very often these become people they're the butt of jokes, and it's in fact usually it's not even brought up.
Versus talking about liver and now talking about the penis in the same conversation, which says that one thing is still related to so many other areas. And we have to take this very seriously, because a lot of times people don't come in saying, I'm getting fewer erections. People won't come in and say, oh, my belly fat. I mean, I do get a lot of people coming in and saying my belly fat is an issue, but it's more of like an aesthetic thing. I don't like having the belly fat, right? And then you find all these things. And I just said to a patient yesterday, I said, you're 65 years old. We've been working together for over a decade, and you've never thanked me for helping you to not get the heart attack. Right? And nobody does. Nobody's going to come to us and say, thank you for sorting out my fatty liver. I've worked with a 20, I think she's 24, and that was amazing. Within 3 months, we reversed her fatty liver. 3 months.
That is usually
lifestyle intervention. Yes. And she did it. But she did it more for the aesthetics and the weight loss part. And she'll never come to me and say, you stopped me from raising my risk for breast cancer and heart disease and heart attacks and strokes and all of these things that you could have gotten. But I am absolutely okay with that because we reversed it.
Yes, that is the interesting part. Most people don't think of reversal of any illnesses, and in the interest of time, I'm going to rush a little bit so that we need to get to the most important part. So number one is what is the diagnosis? I'm not going into it. Basically, most people find out from their ultrasonography, fatty liver is diagnosed. But usually we start suspecting it when we do lab work. So lab work will tell us if the liver enzymes like AST, ALT, and for those of you who use SGOT, SGPT, those are raised. One of the things we think of is, of course, insulin resistance. And routinely all our patients, Natasha, whether it's here, your patients in Calgary or my patients in India, everyone goes through an ultrasound of the abdomen because there's so much of valuable information available. And then, of course, there is a FIB4 index. I'm not going into that. That's very easy to calculate. It's an online calculator. Then there is a test called a fibroscan, which everyone doesn't need. So confirmation of a steatohepatitis, so it is not a fatty liver, is always by a liver biopsy. Because a liver biopsy is an invasive test, obviously it's not recommended lightly. So unless they have, they are progressing, they are worsening, only those cases will they go ahead with the liver biopsy, because liver biopsy is not something we take so lightly. And the next thing is, what I wanted to confirm is, Natasha, this is one of my favorite slides. So when Dr. Iyer and I have been talking about insulin resistance, how will you know whether you have insulin resistance? Because no one whenever I talk to any patients, none of them are ever told you have insulin resistance. They say, I don't have any problem with that.
You need to see a functional medicine doctor to find out if you have insulin resistance before it manifests as all of these things. Once it's manifested, yes, we can help you reverse it, but it's best to find out sooner than later.
So the problem is, diabetes is, so when we talk about diagnosis of diabetes, it's like you've crossed a certain threshold of blood glucose levels. And that is when your doctor tells you, you have diabetes, you need to first, of course, the standard recommendation is always lifestyle first and then medications.
And by the time you're diagnosed with diabetes, your blood vessels have aged 10 to 20 years on average, 15 years more than it should be. So when you're 50 years old getting diagnosed with diabetes, your heart and your blood vessels are now 60, 70 years old. And that's where the problem arises. That part is hard to reverse, right? We
Yeah.
can manage it, but we can't reverse it. So we want to find it earlier in the continuum before your dysglycemia and your glycation of proteins have started to impact your vessels, because those all, like this heart disease and the strokes and every other area I talked about, they're all blood vessel related.
Yeah, thank you, Natasha. So my point in showing this slide is you may have been diagnosed with diabetes here, let us say this is time, but 7, 8 years before that, you have been taking a medication for hypertension. Hopefully you're checking your blood pressure regularly, or if you are a woman, you may have been diagnosed with pregnancy diabetes, or you may have had PCOS. All these are in the same continuum. Another big way for you to know whether you really have insulin resistance is belly fat. So Natasha, among South Asians, you are talking about people in their 60s. Among South Asians, hypertension, cardiovascular disease, heart disease, stroke, these heart disease particularly, occurs about a decade before the Western population. So essentially, a lot of the problems are actually starting in childhood. That is the sad part. So you may have had high blood pressure for a long time, but you're not thinking that you are on the diabetes continuum. You may have had fatty liver for a long time, abnormal lipids, like you talk about, my cholesterol is abnormal, or you are on a statin medication because your doctor says your LDL is not in the range. But very often, no one talks about the triglycerides, Natasha, and high triglycerides are a much more significant risk factor for heart disease, particularly in women. And statin medications are not going to take care of triglycerides. So triglycerides, fat in the liver. Yes, sorry, Natasha, I interrupted you.
Let me tell you the craziest story. Your mind will be blown. I had a patient, she's lean and gorgeous, and she was in her 50s at the time. Came to see me for wellness, bioidentical hormones, the usual.
Yeah.
And she's a vegetarian. I looked at her and she had a history of colitis and autoimmune disease, and she had high triglycerides. And I said, one, you have insulin resistance from your blood work. Two, you have high heart disease risk. Triglycerides are an independent risk factor. Forget your whole cholesterol and whatever everybody else thinks. And she looks the picture of health. In fact, for a 50-some-year-old, she was like way like in the 95th percentile for looking awesome, right? Like just lean and fabulous, stylish and all of that. Anyway, she ends up with a cardiac event. She ends up, because she didn't believe me to eat more protein and less carbs, and you can't do that easily as a vegetarian, as you know. So that's why I brought this up, because a vegetarian diet is certainly very difficult to manipulate enough of a carb lowering with an increase in protein to reverse fatty liver, which I'd like you to talk about triglycerides and the pancreas in a moment. But she ended up with this cardiac event, and her cardiologist told her that triglycerides didn't matter.
Natasha, you kidding me?
I am not joking.
Her cardiologist said triglycerides don't matter for her.
It is a real life story. And I honestly said, you need to get a new cardiologist. And I said, even if you don't look at medical studies, just use Google. Google what triglycerides have to do with heart attacks and see if it says anything. And then, of course, it shows up from the Mayo Clinic and Johns Hopkins and all of that. They have articles for patients about triglycerides. So triglycerides are truly very important. And if you are eating significant carbs, go into that whole mechanism between the pancreas and insulin and how the triglycerides go to the liver and store as fat.
So Natasha, in the interest of time, I think we're going to leave the pancreas and triglycerides for another conversation. But here we'll just talk about what can you do if you have high triglycerides, and what is high. I think we'll Natasha, we'll need 1 hour to talk about what is high versus what is optimal.
Okay, here it is in a few words. Avoid carbs. Carbohydrates drive triglycerides, drive fatty liver, all carbs. The worst carbs are fructose. For
Yeah.
some reason, and not some reason, but it's been shown that fructose, which comes from fruit, so you're very healthy, eating your bowl of fruit and your smoothie made of fruit, that is terrible for your fatty liver, because it just directly, because of that whole mechanism, becomes the type of fat that can go and get stored in your liver. But all carbohydrates get stored as fat via the hormone called insulin. And we want to keep insulin very quiet when we are dealing with fatty liver, insulin resistance, belly fat, heart disease, cancer, strokes, high blood pressure, whatever disease you have. Manage your insulin by managing your carbs. Your insulin comes down when you don't stimulate it by consuming high carbohydrates. And for the average person, they have no idea how to eat low carb because they're having toast or muffins or granola or cereal in the morning, or oats for breakfast. And by the way, I have a patient who according to the advice of her cardiologist, started eating oats to lower her cholesterol, and it actually went up. Right. And I laughed at her and I said, studies. She says, but there's studies. That's why he told me this. And I said, yes, but all studies can be manipulated. And here's the proof. You ate oatmeal for 6 weeks, and that's the only thing you changed, and your cholesterol went up. She was trying to avoid a statin. So, rule number 1, rule number 2, rule number 3, all the way to rule number 10, it's all the same. Cut your carbs. Keep your insulin stimulation low.
So when we are still talking about carbs, I want to bring up a little bit about fructose, because that is one of the problems people don't think when they're thinking in terms of fatty liver. So the problem with fructose is it does not raise blood glucose levels, it does not raise insulin levels, but it goes directly into the liver. Now, the thing is, the fact that the fructose is going into the liver is not something you can see just like that, because it's not raising anything. But that is where this is what I call, it's a stealth bomber. You don't realize what mayhem is going on in the liver. So where does most of the fructose come from? Now, the big bad sources are, of course, the soft drinks, or cold drinks, as they call in India, all the soda. But the other thing is, Natasha, you brought up something very important about the fruit smoothies. So we talk a lot about, you need to eat food as Mother Nature made them. In fact, I was called out on this at an event in Mumbai. I said, you need to eat food as Mother Nature made them. And 2-3 slides after that, I'm talking about fruit is nature's candy. And so this lady got up and said, just now you told us to eat. So Natasha, will you explain that smoothie thing versus how would you recommend someone eat fruit?
So the first most important thing is that fructose is hiding in everything. So I bring up fruit because fructose, everyone knows it comes from fruit. But now there's something called high fructose corn syrup that is one of the worst inventions. It's a huge money maker, and partly why people get addicted to fast food and junk food. And okay, we can talk forever about all of this stuff. But high fructose corn syrup is in your soda pop, in your cool drinks, and fruit juice that's supposed to be healthy. Like, have you ever seen these vegetable juices that they sell and they taste so good? How can it taste that good if you didn't add sugar to it? So they take sugar from the fruit and concentrate it and put it in. So your carrot juice, if you read the first ingredient, it's actually apple juice, and it's actually grape juice. And then somewhere down there's your carrot and tomato juice, but because you've got all of this other. And so beware of your labels and know what you're putting in your body. So I always just say, if it comes in a can or a box or whatever, just don't have it. But high fructose corn syrup, it's in baked goods, it's in processed everything, it's in your drinks, it's everywhere. Then a lot of people eat fruit, like, and I wonder where the term came from, eat your fruit and vegetables. And
I know.
Eating, because people eat more fruit than their vegetables because it tastes good. It's nature's candy. So I have patients going, oh yeah, I start with this nice large bowl and I cut up banana and pineapple and I use some frozen mango, and then I put my granola and I put my yogurt, and so that's healthy, right? Wrong, right? Wrong, because the carb count is probably 40, 50, 60 grams of carbs in that one serving by adding the granola and everything, and that tiny bit of 5 grams of protein does nothing from the yogurt. So that's one thing. Then people think, okay, I should juice. Well, in juicing, you're concentrating all of the sugars from the fruit, and you're getting rid of the fiber and the other nutrients that are needed to slow down that spike of sugar as well. But in the smoothies, you'll have patients make a big jug of a smoothie, and bananas are high in sugar.
Very.
Mangoes, pineapple, all the things that taste good are high in sugar. And when you use things like, we live in Canada, there are no real tasty, juicy strawberries and other berries. They're nice, but they lack the oomph of eating a mango that came from Hawaii or from South Africa, right? Like that's tasty, or from India even, right? So we want things that tickle our taste buds, but they're fueling disease. And so we just,
Thank you.
we have to think about vegetables and fruit instead of fruit and vegetables.
So, we talked about, so Natasha explained this very beautifully. So when you make a fruit smoothie, number one is you are taking away all the fiber. So it's not just, you need to eat fiber to, to prevent colon cancer. Yes, that's important. But if you think back to the time, so Natasha, I grew up in India in a multi-family home, and fruit back then was seasonal. Like mangoes, you brought up mangoes, one of my favorite fruit. So we had a mango tree at home, and we would probably get one mango because we were kids. Older people in the family didn't get one whole mango, but that would not be every day. Versus now, it's like, you get mangoes from Mexico, and you buy, I don't know how many, 4 or 5.
A crate of them.
And you can eat the whole lot at just one sitting. So that is the other big thing, because fruit has no longer remained seasonal. So we can just go to the grocery store and buy as much as we want. That is number one. And it's so easy, like cherries were one of the things. Anyway, so number one is fruit, and not in a liquid form. That is not a health drink. Fruit juice is not a health drink. It's pure poison, actually. That's what I say. So Natasha, you brought up about the smoothie. One of my patients got actually quite offended when I said you're drinking candy in the morning. Anyway, she said that was a dietitian's recommendation. I said, no, that anyway. So number one is the fructose coming from all the soda and cold drinks and all those things. Natasha, believe it or not, there are some people who think that one glass of red wine is worse than a glass of soda. They think they're making the healthier choice when they're choosing the fruit juice. And again, full disclaimer, Natasha and I love red wine. We are coming to wine later on. But one glass of red wine versus like a sugary fruit juice or a pop or something like that, it's you can't compare. It's like
I can get down another rabbit hole and go, it depends on the red wine, because obviously the red wines have lots of additives and sugars and things. But we're talking about your more refined palate. Probably let's say $25 or more a bottle of wine is probably a good place to start if you don't want to.
Natasha, we'll have a separate wine discussion. Maybe with glasses of wine. Anyway, so because both of us can, we can just keep on talking until kingdom come.
Okay, let's get to the next.
Let's get on to the next one. Now, the most important thing is lifestyle intervention is the fundamental and only treatment of non-alcoholic fatty liver disease. Now, here I want to clarify, this is from the guidelines. This is not something that Natasha and I brought up. But I want to clarify here, fatty liver and non-alcoholic steatohepatitis, that is already inflammation is severe. Mm-hmm. That is a different state. So in medicine, no one is recommended a pill for, fatty liver. That is not what the guidelines say. The guidelines says about using prescription medication. I'm coming to that later on. When it is already inflammation and steatohepatitis, so not fatty liver. Now, when we talk about lifestyle intervention, what are the different lifestyle interventions we talked about? One of the most important ones is weight loss. So Natasha, you get a lot of patients like that, and we also think like that if we haven't achieved, the 20 pound, 30 pound weight loss, and we are not where we like to look at ourselves in the mirror, it's insignificant. What
Even
I want to stress upon,
blood pressure changes with 10% of body weight.
yeah. So 5 to 10% of body weight loss, and more importantly, being able to maintain that, has a huge number of different changes in respect to your risk for heart disease, your risk for stroke, for mental illness, for dementia, for everything. But most of us
go back to the previous slide though.
Mhm.
Let's leave that now. Carry on, please. I just would like people to see that a little more.
Okay, yeah, I am going to summarize it at the end because we are, in the interest of time, I'm just rushing. So my point is weight loss is one of the most important therapeutic modalities for fatty liver, as it is for a whole lot of other conditions. But again, going back to a question of, so Natasha, I could make it into a prescription medicationable, that wouldn't sound good. So here is a study where they used a prescription medication called liraglutide versus intensive lifestyle management. And as you can see, of course, intensive lifestyle management, for weight loss, both of them work well. For fibrosis, both of them work well. But what happened is when they stopped the liraglutide, the weight gain came back. So they started gaining weight again. And again, liver fat also increased when the liraglutide was stopped. So which means if you want to use liraglutide to reduce your fatty liver and you don't want to do anything in lifestyle management at all, then once you stop the medication, it'll come back. However, with the intensive lifestyle management, it remained at low level. Now, Natasha, what I want to highlight here is this particular study. They had done intensive lifestyle management for 26 weeks. So that's longer than 6 months. So what I was thinking, from a practice perspective of how we can help our patients, I'm thinking for 6 months, I wonder how much an intensive lifestyle management program costs, because as you know, intensive lifestyle management is not something that just one practitioner does, it's just me or Dr. Iyer. We need a team. Actually, I always say we need a village. And sometimes, Natasha, for a lot of people who don't understand what therapeutic lifestyle change is, they feel, oh, it's just lifestyle change. I'm just going to give them a handout which says you need to exercise for, 40 minutes a day, 7 days a week. You need to do a HIIT. You need to do blah, 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 blah. And you need to eat less carbs. You need to do this. You need to meditate.
So you're suggesting that we put on an intensive lifestyle management?
Oh, absolutely. I'm coming to that. So we just feel that if you give them the information, they're just going to go home and do it. So Natasha, hasn't that been what we have been taught? And to a great extent, we were using that as well. And isn't that what the public health message is? That people just need more information.
Well, interestingly, I mean, I teach residents, right? And I have them in the clinic frequently. And so the new thing is that people like to leave with something. So you must write it as a prescription, even if it's exercise. Now, 20 some years ago, when I first started practicing in Canada, we used to do that. I used to write a little prescription for exercise on the pad and give it to the patient. So it feels like, they have something from the doctor saying, I've got to exercise. But the actual fact is, you and I both know nobody goes home and does it all by themselves. There are some motivated people, and there are those, I admire those that just live a healthy lifestyle. They get up, they exercise, they've always eaten well, so there are those, but they're very rare. The average person that we're seeing with fatty liver and all of these risks, they definitely need more support, more coaching, more guidance. And you and I both know this from our own journeys, right? Because you and I have both had severe insulin resistance. We've both had to get rid of a remarkable amount of body fat to be healthier and improve all of our markers, because neither of us—
I'm not there yet, Natasha.
Okay, okay. I've been at it longer than you have, right? So 15 years later, I'd better have some better results. And but the thing is that even on your journey, which is shorter than mine, we take steps forward and we fall off, and then we take step forward and then we fall off. And some days it's just like, I mean, look at this last week, I've got so many things going on, plus I had events and I traveled and I look at myself and I go, I'm completely off track. I've rather been trying to make up my sleep than fit in my exercise. And so there's, and then I'm eating this because I didn't plan, because I was, whatever. So we all do that. There are times where we're really good and then we fall back. But if you have the right structures in place, the right supports in place, and the right information, and I think your tiny habits is even more important, right? So your tiny habits helps patients put the habit in place and then keep it there so that they're successful long term.
Sorry, Natasha, I'm just sending an email to our next
Yep, no,
the
you go
next
right ahead.
appointment, because
So then
you
let
and
me
I
talk
have,
about, yeah, I'll talk a little bit more about lifestyle then. So,
yeah.
if we
So
have to talk about the dietary interventions, it's easy to say cut the carbs. But when you cut the carbs, what does it mean exactly? Well, it means, yes, knowing what a carbohydrate is. So all of your starches, like your breads, your pastas, your rice, potatoes fall in there, because you got to think, what does an average person put on their plate? And it's that stuff that you put on half the plate and you pile it high. Stop it. Okay, like if you're putting your 2 bread rolls and your potato, and then you take a little bit of meat and a couple of vegetables to feel good that you put a vegetable on your plate, that's the wrong way. So take your plate, cut it in half, and put your lean above the ground vegetables first, where you would have piled up the rice or the pasta or the potato or the bread rolls or whatever it is. And then on the other side of your plate, divide it and now put a substantial amount of meat, because you want high protein, and protein is usually attached to a fat. Fat is satiating, meaning fat keeps you feeling full longer. So the biggest obstacle people have to cutting carbs is they're eating this big salad, they're eating all these vegetables, they're eating their meat and maybe a little bit of starch, because I don't take starches away completely. I reduce it, right? And so I say to them, now put the starch there instead of here. And then they'll go, oh, but I get hungry so quickly, then I need to eat again and again. And the reason you're getting hungry by removing the carbs is because you didn't put enough fat on the plate. So you can add olive oil, coconut oil, ghee, butter, all of those things. If you're eating meat and it's a well-sourced piece of meat, by all means, keep some of that skin on, that fat on, because it does keep you feeling full longer. And we know that fat does not cause fatty liver. Fat does not cause your increased heart disease risk. It is old news when they say saturated fat is bad. Now, again, everything in moderation. I'm not asking you to eat like the entire skin off of a chicken or all of the fat off of everybody's steak. Like, that's not the point. The point is what came on your piece of meat. But add good fats to your lean vegetables to keep you feeling full for longer and to keep you more balanced. So cutting carbs is not enough. It's knowing what it is and then reducing it and balancing it so that you're not. Now, the more sugar you eat or the more carbs you eat, the more you want to eat. So that's a vicious cycle. And it's hard because as you're cutting it down, you start craving. But trust me, if you do it slowly and you increase your vegetables, your fiber, your good fats, you do not get hungry and your cravings actually go down, because sugar is so addictive to the brain. It's worse than cocaine, to be honest. The studies have proven this. So when we eat it, and then there's also the insulin surges and the sugar spikes, right? When your sugar goes up and then it starts to come down, you start to feel it and you naturally want to eat more. So to stop that bouncing of the sugar levels and the insulin levels, we want you to eat more fiber, more good fat, more protein, and eventually it stabilizes and you will cope. You will not die without your carbs. I promise. You will not be constantly hungry. I promise. There might be a day or two where you're just adjusting, maybe 3, 4, 5 days even, but to not die is worth it. To not die awfully is even more worth it. My grandma died having lost both her legs. She died drowning in her own lung fluid from heart failure because of diabetes and insulin resistance. And she would take insulin and eat cookies, right? So we don't want this for you. We don't want someone wiping your bum, moving you into the shower because you can't move yourself. We don't want someone coming to feed you and make sure you have your own medication. My grandfather died of 5 strokes. He was a vegetable. I mean, sorry to call it a vegetable, but that's how the common term is, right? I mean, he couldn't speak. He couldn't remember anything. He'd never know who came to see him. It was awful. Like, who wants to die like that? but we want to put whatever we want in our mouths because it makes us feel good for now. But is it worth it for then? No, it's not.
Mhm. Thank you, Natasha. And I'm really sorry to know about your grandparents, but I think that is what drives you towards, being healthier and doing everything that you do. One more thing I just wanted to highlight, because my patients are all from, mostly from India. And in India, there are many people who are primarily vegetarian, so they are not going to start eating meat suddenly. So what I tell them is, don't look at what you're giving up, because many of them are like the rotis, as if it's like your life depends on it. No, it doesn't. So it's like all our traditional food, you're asking me to give up all these things. I said, okay, let us look at what you can do. Number one is prioritize protein and fat. Protein, Natasha, believe it or not, most people are not getting even the minimum they are supposed to get.
I believe it. In fact, I tell patients, when they tell me they eat enough protein, I say, go use an app and prove it to me.
Yeah.
Right?
So number one,
they're not even getting half the amount of protein.
And even I struggle getting adequate protein, though I'm non-vegetarian. So number one is serve yourself protein. That's what I tell my patients. And of course, it has to be enriched with good fat. Then vegetables, like you said, non-starchy vegetables. Then there is hardly any space left for the carb, So I always try to tell patients that don't look at, what food you're being deprived of. Think of all the wonderful, the chicken or, the mutton or the fish, eggs. And of course, for vegetarian people, it's like, the cottage cheese or the tofu and things like that you're getting to eat, which you were probably giving up because your doctor said saturated fat is going to kill you. So no mutton, none of that.
In fact, never mind what you're gaining as far as your taste buds go at this moment. You're gaining a healthy lifespan, a health span. You're gaining, not dying with your lungs drowning in your own lung fluid because you decided you wanted to tickle your taste buds instead of feed your health.
So in the interest of time, I'm going to rush through, but this is something very important because as anyone in functional medicine knows, we talk a lot about supplementation. So Natasha, I don't apologize for how busy this slide is. So basically, what are mitochondria? Now, mitochondria are the energy generating organelles in your cells. Every cell needs energy. Your brain needs a whole lot more energy than any other organ. It's just 2% of your body weight, but it needs about 20% of your energy requirements. Your immune system is another big one because of the ongoing pandemic. Everyone's very, interested in improving their immune system. Your immune system needs a lot of energy to function. So what this slide is showing is what are the different nutrients that are necessary for your mitochondria to make the cellular energy called ATP. Natasha, I'm very quickly going to close this and add. So this slide, this graphic actually had all these vitamins and minerals in, shown there in different colors. I'm just covering it for now so that people don't get distracted by the complexity. My point is, and again, for this, I must thank Dr. Bonnie Kaplan and Julia Ruckledge, who have brought this out in relation to mental health challenges. So you need about 13 different nutrients for your cells to make adequate energy. But what happens in most clinical studies and things like that? So mitochondrial dysfunction is supposed to be, nowadays, a lot of research is coming out where almost every disease is looked at from the perspective of the mitochondria. So poor energy production at the cellular level. This is not how energetic you feel or any of that. So when we look from the perspective of the mitochondria, now in this list, you can see there are 13 different nutrients. And in relation to fatty liver, the only studies they talk about is the one with vitamin E, and that too, it is alpha tocopherol, and I'm not going into alpha tocopherol versus mixed tocotrienols. My point is, you need so many nutrients, and all you want to do is use one. Like, how is that going to work?
So then the study comes out and says vitamin E doesn't work.
Yeah.
Well, this thing doesn't work. Well, yes, because there's that many things interacting. And that's what I don't like about nutritional studies, to be honest with you, because it feels like the ones that make it out into the general public are all biased towards proving that nutritional supplementation is not essential or necessary. And it bugs me because our whole body can only function based on having the right nutrients, which is the fuel for the body to work, whether it's your brain, whether it's your mitochondria, whether it's your heart. Absolutely every cell in your body needs nutrients. And we're all nutritionally depleted. So thank you for this slide, Dr. Carr. And to show people that it is absolutely a combination of multiple nutrients and not just any one alone.
Yeah. So this is what, Bonnie and Julia call that the magic bullet thinking. And I think the reason is a lot of that thinking comes from the world of pharmaceuticals, because in the pharmaceutical world, people are always looking for one drug target because it's not a broad spectrum. Like one drug is not going to have 3-4 different ones combined, at least not at the beginning. Versus in the nutritional medicine world, in the world that Natasha and I live in, just as in the pharmaceutical world, people are looking for drug targets, we are looking for nutrition and supplementation targets. And that is the exciting thing about, practicing functional medicine is I don't have to worry about, is this medicine going to, deplete them of magnesium or potassium, or it's going to fire their brain, or it's going to damage their kidneys. We are talking about things that are, I have not come across anyone dying from normal doses of vitamins and minerals versus, a lot of prescription medications, even accurately prescribed, have caused problems. So actually, Natasha and my job is easier because we don't have to make those difficult decisions of this versus that. And one more thing, Natasha, while we are, I just want to highlight the omega-3 because, we know that we can test for omega-3 levels, and that test is available in Canada. In India, it's not yet available, but we can, if any of you are interested, just send me an email. I'll tell you how you can do it, because it's a dried blood spot test. So why am I bringing out the omega-3 testing? Because both of us believe that, why should you guess when you can test? Like, how much omega-3 do you need? So this particular study, they actually looked at how much omega-3 was there in the RBC. And this is not a test that is available on healthcare or just a routine lab. It's a specialized testing. So what they found is those who had an increase in their omega-3 levels of more than 2%, that would, help in reducing the liver fat. And the other thing I want to highlight, Natasha, is see this particular test paper, they looked at it for 18 months. So I'm sure a lot of patients come and ask you, Dr. R, do I need to continue taking these supplements?
Yes, you must. Everything is long-term. This is not short-term things. And especially because it's taken you a lifetime to get nutritionally depleted. We're not going to be able to replete you in 2 months. And partly, and people can say, but why? If you gave me enough, why can't I build up my stores? Because your body's still working all day long and everything's still happening all day long. And you're still dealing with toxins all day long. And you're still, going out and having wine. Maybe not all day long, I hope, but regularly, right? Or whatever the case may be. You're exercising, you're using up nutrients. You think you use up nutrients. You breathe, you use up nutrients. So it's very hard to ever get fully repleted, but you will notice that when you start feeling better from nutritional repletion, it takes longer to feel worse if you miss a couple of doses or days or, and I've had patients tell me that I went on holidays for 3 weeks. Just recently, this lady was feeling amazing and she came in with her thyroid not working and a whole bunch of issues. And then she went on holidays and didn't want to take all her supplements with her. And she said for the first week, she felt okay. But the next week and the third week, she could feel the distinct change and heading back to where she was when she started. She never imagined that just not taking supplements, because she kept everything else was the same, other than her environment. She was away for 3 weeks. But when she came back, the first thing she did was start taking the supplements, and then could see for sure that she was feeling better from adding back the supplements. And so she said, I would never have believed it had I not done the test for myself, but this is what happened.
Thank you, Natasha. So one more thing I just wanted to mention about omega-3s, it is an essential nutrient. That means our bodies don't have the ability to make omega-3s. And if you were to try to get this much of omega-3 from your food, good luck with that. Mikhail and I have a podcast on that, so that's for another day. Bottom line is you will never get
And when patients
enough
tell
from
me I
food.
can get enough vitamins from my food, I go, yes, and you'd be 300 pounds overweight as well, because that's how much food. By the time you calculate your daily requirement for magnesium and then eat 2 pounds of broccoli to get that, or whatever, and then you need so many milligrams of vitamin, so many grams of vitamin C in a day, and then you're eating a bag of oranges just to get that. Well, where do you have room in your stomach, and how will your body fat be if you try to get everything from food?
So, Natasha, in the interest of time, I'm not going into the liver clocks and how your metabolism gets disrupted when you disrupt your body clock. That is for another conversation. So, who is the high risk liver patient, fatty liver patient? The one with diabetes, hypertension, living with obesity.
Insulin
And
resistance.
yeah, so the thing is, the worst liquids for fatty liver, we've already, I think, beaten that to death. So all the cold drinks and fruit juices and soda and stuff. What about alcohol, Natasha? What would you say?
Oh, I want to say nothing, because then I might have to rethink my alcohol consumption.
So yes, alcohol is not your friend, and that is because, and both of us, like I said before, we love red wine, so we understand what it is and how it is. So yes, but we didn't make the rules, you see. Alcohol is processed by the body in a very different way, and there is no way for the body to store alcohol. And Mikhail talks about this oxidative priority, and we have a podcast on that. So your body has to process the alcohol very quickly. That is one problem. So if you have more of it, and then the other problem is, what are you eating along with the alcoholic drink? So in India, Natasha, they have a lot of these high carb snacks along with alcohol. It's not a meal usually.
Well, in
So,
Canada, it's not that much different. You're having nachos and beer, you're
yeah.
having chips, and you're having peanuts, which aren't optimal as far, I mean, I said eat nuts and seeds and all of that, but I mean, you're eating peanuts, but it's the chips, it's the snacky things. Nobody snacks on a piece of steak.
No.
Nobody snacks on beef jerky while they're drinking red wine. Like, you just
Yeah.
don't do it.
So so alcohol is definitely not what we are recommending when we talk about the
I
most
think
harmful liquid.
to clarify, alcohol and the way it's metabolized by the liver, it affects how the liver functions as well. And that's why we don't want alcohol as part of your daily living. We're not saying never drink alcohol, because a
Mhm.
lot of people get really angry when they think that that's like, we didn't say never eat a piece of bread again. We didn't say never eat a mango ever again in your life. We never said,
Yeah.
we're talking about the total global intake, and whether it's excessive or not, and whether it's low enough to reverse what you've got going on, and then finding out what is right for you. And that's what we do: predictive, personalized, precision medicine, right? And so what my tolerance for alcohol can be after I don't have fatty liver, well, I've never had it, but let's just say I did and now I don't, I can go back to some measure of eating and drinking what I might want. I just won't be able to do it to the same way, because if you go back to the same way, you're going to get the same result. So what would be the point? But we will find out what is good for you after.
Yeah, so we talk about metabolic flexibility. And again, I'm just summarizing a lot of stuff that we talked about. Number one is fatty liver is not all about the liver. Most people with fatty liver die of heart disease, stroke, and all these other conditions. Number two, it is reversible. That is the most important thing. And the reversible part of it depends on lifestyle changes. And Natasha and I know how to help you make those lifestyle changes, but it's not as simple as taking a pill. And it's not as simple as going through, a PDF of an ebook or, of 20,000 videos. That is not going to help you. So that is where both of us are very excited about launching some new programs. So watch out for that. Tiny Habits is I got recently trained as a coach, and more about that later. But
I think
basically,
that is what people need the most. It's
yes.
that tiny habits coaching, because it's easy to do the programs. It's easy. I ran a really successful program last year called Vitality and Maximum Health. It was amazing the results people got, and a year later they don't got it anymore.
No.
Most of them don't even remember what we did, and it's very sad. But the thing that was missing the most was that tiny habits coaching. If we had implemented it at the time and people had just made 2 or 3 huge, like, there's different things that move the needle in different ways. Like
Yeah.
there's some things you can make small steps and have huge impact, like
Yeah.
skipping breakfast, just a simple thing. Don't eat breakfast. That intermittent fasting can have a huge impact on your insulin over time. So if that's a habit that can stick, that's great.
Thank you, Natasha. So one is reducing your carbohydrate. Don't drink your, fruit
Carbs.
juice and soda and all,
Don't
fructose.
drink your carbs.
Yeah. And the third thing is if you can incorporate time restricted eating, and don't have time to talk about it, because particularly, Natasha, I found for my vegetarian patients, because they cannot reduce their carbohydrates beyond a certain level, because whatever their protein sources they think are very good, like lentils and beans, all of them come with carbs. So for them, intermittent fasting is like the best tool possible. And
we have a video on intermittent fasting.
yes, we do have quite a few videos. So thank you everybody for joining us. And as always, we just go down many different ways and we can talk until kingdom come. Thank you very much. Okay, bye.